The program we're going to have today is not just about cooking. This is also about the meaning of food, right? And so I'm very blessed to have my dear, dear friend, Leanne Burns. Come on up, Leanne. Get up here. Kind of have a round of applause. Leanne is a clinical nutritionist, registered dietitian, who I've known for 15 years, actually since I graduated from school. And she actually is one of the people who wrote the cookbook you'll see up there. We don't have that many copies, but you can take a look at it. And she understands neuroendocrine nutrition probably better than anyone in the whole wide world. So I am hoping and praying that she can continue to work with our younger nutritionists so that they can take on the knowledge that she's gained over the years. So do me a favor. What we're going to do is we're going to have a session at the very end, a panel session. So save your questions till the end. And we'll get through all the speakers. And then at that time, then we can have an open conversation. And so once we finish the open conversation, we'll have bread, we'll have more food, but more importantly, I have already played some Elton John before the camera started. So if you guys can hang around, we'll have a lot of fun, okay? So Leanne Burns, please. Thank you, my darling.
Thank you so much. I love this man. I don't travel much anymore, actually very, very rarely. And I wouldn't travel for probably anybody but Carolyn and Dr. Lou. So y'all can thank them for me being here today. This is a lot of joy to me. So you gonna show my slides or? So just to give you a little bit of background, I'm very southern. I'm from New Orleans, a little bit above New Orleans. I was part of the faculty for LSU Medical School, and all right, great. Since 2000, and I had the opportunity to work with, some of y'all will know some of these names. Some of you may have met these physicians through the years. Dr. Lowell Anthony, who is a leading specialist, also a neuroendocrine and a researcher. And I went and practiced with him. And then we joined up with surgeons in our group. So we had Dr. Eugene Waltering, who passed this year. We are going to really miss him. Dr. Boudreaux and Dr. Wang. So I was able to work with people that knew a lot about it. So I had to get good because I had a lot of patients coming in. And I realized real quick, and I had been oncology dietitian when I went to New Orleans for about 15 years. But I realized that these patients were like my other patients. They were very, very different. And the things I could do with other patients in oncology, I could not do with neuroendocrine patients. It was different. And I had to learn to pull from other disease states and other things that worked with other people, and put together some information and met a wonderful physician along the way, Dr. Bill Goh out of UCLA, and we had Dr. Warner's wife, Monica Warner, who was a dietitian, and the three of us put together guidelines, and these were printed back in 2010. We were very lucky that a lot of people had picked these up and printed them. I was able to do a good bit of publications through the years, and have had pharmaceutical companies that have been really wonderful to back me and use my ideas and information to give you all the information. And that's what it's all about. Is my goal now, I don't go to professional meetings. I only take care of patients. So I do education for patient support groups primarily, and I enjoy it. So I'm here for you. This is what I do. So I'm going to go through a little bit with you today on how do you choose the best diet for a neuroendocrine patient? What is the best diet? Next slide. Okay, so selecting a diet for neuroendocrine patients. A diet which contains foods and fluid with nutritional value which the body can tolerate and absorb is the best diet for a neuroendocrine patient, okay? Because this is a disease of malabsorption, isn't it? If you have it, you know that. This is a malabsorbing disease. This is when you have either chronic diarrhea or a lot of malabsorptions, eating's not easy, a lot of symptoms, gas, some nausea. And so if you can absorb the foods that we're going to present, then, or out there, that's what your best diet is. It's not necessarily what we see and what people and even everywhere I go, consider to be the healthy diet, okay? And it's not full of raw vegetables. It's not salad. It's not necessarily sweet potatoes, okay? It is foods that your body can absorb. And sometimes these are breakdowns of the old white potato. You know, these are things that easy to absorb rice. You know, I live in South Louisiana. We live on rice, right? They think all that fried food's why we're heavy in South Louisiana, but it's really the rice. It's rice. But rice is very easy to absorb, and it makes a great electrolyte drink as well, and you'll see that. And so it's a little bit different, right? It's not always those foods that we assume. So next slide. So this is what the USDA put out, the guidelines for nutrition, and these are available at choosemyplate.gov, and this is for everybody, okay? And this is what a normal diet would look like. This is what if we want all Americans to pretty much eat from this guideline, okay? This is it. Next slide. But neuroendocrine's we're going to modify that, so we'll talk a little bit about that as we go along. I did put up here, it's been really interesting. So a meal plan that we are working with and with the registered dietitians that we have, we kind of use this as our general guidelines set out. Most women use between 16 and 2,000. Now, if you're a runner and you're really working out and stuff, or if you're a patient, or if you have liver disease, this goes up, okay? If we're sedentary, it may go down a little bit. So, but that's kind of our range. Men, you get more. So theirs will go up a little higher. But when we want to increase weight, and sometimes after surgeries and things like that, where you've lost weight, you've had treatments, and we're losing weight, and we want you to gain back. So it's a little. So if we want people to gain weight, 3,500 calories is equal to 1 pound of body weight. 3,500 calories. So I'm going to give you an extra 500 calories a day, and in that week, in 7 days, I hope to gain a pound. Okay, so that kind of gives you the guidelines that we work from, and then to lose it, we reverse that. We take out 500. So that's how we manipulate weight, and that's a general guideline, but it works for the most part. All right, next slide. All right, and also everybody's different. That's one thing about neuroendocrine. Many of y'all know that the zebra is kind of our mascot. You know, they have the thing we symbolize with. But what about zebras? They all have different stripes, right? And so all of you have different stripes. Everybody's a little bit different. Your disease is a little bit different locations, different tumor sizes, the surgeries, treatments you've already had are a little bit different. So no two zebras may be alike, okay? So your diet and choosing things that work for you, we go into a lot of other things, and one of them is your medical history. So yours may be related to other things going on with your body that maybe someone else that's in your support group may not deal with, okay? So yours may be different. So just because it's good for one person, it may not be good for somebody else. Everybody's different. So we'll talk about that. And then our meal plan, you know, how we set up meal plans. So, but these things are things that we really worry about. Mostly, I may have to do, diabetes is very common. If you have had a Whipple or something, many of you now are taking insulin. So that's one thing. Long-term hypertension can cause kidney disease in anybody. So sometimes we see that sometimes as a side problem. Liver disease, fatty liver is very common. I live in New Orleans, you know. If you're in New Orleans or Louisiana, you don't have liver disease, something's wrong with you, no. But we do see a lot more of it than normal. Obesity, okay, I'm in New Orleans, so I'm not gonna say anything else about that. I'm a 20-pound up, not a 10-pound upper instead of a 10-pound down. Because if I'm getting you ready for surgery, I don't want you skinny. I want you up. Because almost every liver surgery we do, you're going to lose about 10 pounds, okay, real rapidly. It might be a week, it might be 2 weeks. I know that because Dr. Boudreaux had to reset mine because I had a hemangioma that ruptured. So I've had a liver surgery, and I lost 15 pounds in 7 days. So I know that. So I'm an up one. You know, I'm not a skinny, I want you up a little bit so I'm prepared for something. So if you're getting ready, you know, so there's times we really want you to try to pick things up. Surgeries, longevity, I mean, if you have the more surgeries you have, we tend to have more scar tissue that we're dealing with. And these many times can cause adhesions where you reconnect you. And right after surgeries, can be really hard because like when you get a cut, you see that red, you know, that takes a while to settle down. And so sometimes we see these being a problem. We'll have and sometimes we see small bowel obstructions, and that's one thing we'll put you back in the hospital. Okay, so partial bowel obstructions are not, you know, they can happen, and they're really not rare. So that's pretty common. So these things can happen, and so that's why we change your diet. Okay, next slide. And a lot of the things we're going to do based on the type of tumor. Again, neuroendocrine is not just one tumor, is it? It's a spectrum. You know, it has to do with, it can be different tumors, and those tumors release different hormones. Okay, so your diet and what's going on with you is also going to depend on your tumor and how we treat it. So some people have no problems, and that's great. And if you are having no problems with your GI tract, then, and you're not having trouble with hydration, then when you saw that first slide, the ChooseMyPlate.gov, you can eat just like everybody else. So don't think, if you really have a normal GI tract and you're not having problems, don't think you have to go by all these guidelines that you're seeing in neuroendocrine tumors, because these things don't cause tumor growth, okay? They're doing it for symptoms, and I think sometimes people get really confused about that. So we see some people that have a lot of problems with digestive problems, nausea and vomiting, diarrhea, steatorrhea, which is one of the biggest problems, fatty stools. They float, and they smell very foul, okay? And constipation. And some people they just can't get them to move. You know, everybody else is going one way, and you're going the other direction. So carcinoid syndrome, many of you have been put on medication that prevents your syndrome. And these have been great. I've been doing this since 2002. You know, we didn't have a lot of these medicines when we started this game. And I wrote a lot of information and for pharmaceutical. And so when I was doing these articles and when I was writing this information, I was writing it for syndrome, right? A lot of people don't have syndrome. So you don't have to necessarily do everything you see in handouts that say syndrome, right? You're different. You don't have that. Flushing. Flushing's interesting. Flushing usually comes from the aging process of foods, okay? Fermentation, smoking, smoked foods, prepared foods ahead, softening of vegetables. Then bananas, they get soft as they ripen, don't they? Right? So you may be able to have a lightly green on the riper end, you know, on the less ripe end of a banana and not have a problem. You may get but if you let that ripen, then you may flush, okay? It's the aging process. Guess what else does that? Leftovers, because you've cooked that food, you've set it out, you let it age, right? And then you put it maybe in the refrigerator, and then it stays there for a day or two, and people will say, oh, I can tolerate it, but then after that I can't tolerate it. You know, I don't know it. Sometimes I can, sometimes I can't. Well, sometimes it's the aging process. So I want people to go ahead. When you cook, put it up then. Get your little containers. Everybody needs frozen food when you're a patient, right? Because you never know when you're going to have a bad day. You want to bring something out of the freezer quick, easy, and in portion sizes. So I say, go ahead and put it in containers that have portion sizes and put them in the freezer. And then they're ready for you next time, right? They haven't aged so much because that freezing process really reduces the ability for it to continue to age, right? So that's really important. Hyperglycemia is very common, sometimes medications, especially if you're borderline. Like we used to use that term a lot, borderline diabetic. Well, if your blood sugars are kind of riding around between 90 and 100, and you go on some of our medications, the sandostatin, lanreotide, some things like that, it may go ahead and push your blood sugars on up. So you may cross that line when that happens. And fatty liver, I think it's common, just really for a lot of it's from old eating habits, and some of it, we'll see a little bit of this with disease as well. Next slide. So all diarrhea isn't alike. Everybody you'll see on the chart, they'll say, oh, they have diarrhea. Well, I'm a dietitian. I worked with a loving, I spoke his name already, Dr. Eugene Waltreen, and he said it, called it like he saw it, and he would introduce me to people as the queen of poop. I was the queen of poop because I specialized in figuring out which type of this diarrhea you had. And they would send every patient I saw. But I was privileged because many times as dietitians, in oncology in particular, we may see people of every type of cancer but never see a neuroendocrine patient. And in my practice, I had the ability to see 300 neuroendocrine patients a year. And I practiced for about 12 years. So what did I do most? I listened to my patients. I watched the symptoms of everybody. And I learned. I learned from you. You know, I watched what everybody was doing. So I just had a little bit of advantage because I got to see it a long time. But this is what many of these things cause diarrhea. Short bowel syndrome is many times where they've had to go in and reduce, you know, take your tumor out, reduce your GI tract. inflammatory bowel disease, which is not necessarily always in just neuroendocrine patients, right? That's very common, but it can definitely increase that. Celiac fruit, you know, that's a real malabsorbing disease, and it will do that. Pancreatic insufficiency is one of the areas that we see a lot of it in neuroendocrine. Because the drugs we use, when they shut down this syndrome, they shut down a lot of things. They shut down your other hormones and some of your other enzymes and things that are released. So we see this become a problem. And we have treatment, though. We have pancreatic enzymes now, and good companies giving them out. So I can usually feed you pretty normal to get you to digest fats, and that's what we're really working for, because the problem we mostly have is digesting the fats in the diet. And then, so that gives us one more crutch, right? It gives me something else in my tool bag. Intestinal surgeries, these are very common, and especially in neuroendocrine, and any of those can just mess with your GI tract for a while. Sometimes it's temporary. You know, we can get you a couple months out of surgery and you'll go back to pretty much normal. Bacteria overgrowth, we put you in the hospital and we don't let you eat for 2 or 3 days while we're testing you. Or surgeries when you have to wait this long time after surgery while we're getting you ready. Sometimes the bad bacteria will overtake the good bacteria, and we'll see that cause a really bad diarrhea. And we treat that with drugs, to get rid of that, kill that bad bacteria. But mostly we use a normal probiotics. Have y'all heard probiotics? Acidophilus and things like that. Bile acid colitis. Well, some of us, when we have our gallbladders taken out, I had mine taken out, we still have bile releasing into our GI tract, right? It's going to still go in. Some of us, if we, especially if we don't eat, or if we're afraid to eat because we're afraid we're going to have diarrhea, and so we wait all day long, and that little bile's been dripping into our GI tract, and then you eat something, and it pushes it down the GI tract, gets to your colon, and you're done. You're out. So, but you usually know it's bile acid because it will burn your rectum. You will have pain. And so we use different drugs for this. And we have cholestyramine. It's an old drug. It comes in powder form. And then there's different drugs, and they're hard pills. But I am a believer in cholestyramine. I use it personally. I travel with it. I mean, I don't have to take it when I'm at home. But boy, get me on a plane and come here, and I've been loading with it ever since I got here. So it's a pretty unique one because we can titrate it. You may not have to have the whole package. You only have part of the packet, and it can be used a little bit independently. But another tool in my bag. Drug-induced, the somatostatic analogs, and those are the drugs that we're using to treat these syndromes. This is the drugs, and they again they have some side effects as well. And so if they're shut down, your fat absorption, sometimes that can cause steatorrhea. All right, next slide. So diet should be healthy. We want all Americans to have a balanced diet, low in fat and sugar. All Americans, not just people that are sick, not people that are malabsorbing. This is normal for everybody. Next slide. So I'm going to go through some of the foods, and I'm not going to, because y'all know foods too, and I'm going to want other dietitians to talk, but I'm just going to run through. We worry about protein. I think, do they have a copy of my slides in their bag? Do they have, Carolyn, do they have a copy of my slides in there?
We're going to make that available in an email.
Okay, all right. So we're going to just go over the big topics. Like I said, I want these younger dietitians, I want you to hear what they have to say too. But what you'll see in here is we use protein from different sources. We try to use lean ones. We try to avoid a lot of the fats, except for you'll see peanut butter, and peanut butter can be tolerated. I've seen it tolerated when nothing is. But I can use pancreatic enzymes if I need to, all right? And it's a good mixture of both protein and a good course. You have a little carbohydrate there as well. And quinoa is a vegetable grain, and it's considered almost a total protein. So it's very useful in proteins. All right, next slide. So we need this, proteins are usually increased during treatment, and this just gives you a range of how we do it, and we increase your protein times kilogram of body weight when you're coming off a post-op, because your body really is burning a lot of protein. And you may see wasting. That's when we see the wasting. Sometimes you look in the mirror and you'll see it right up in here and your temporal, you're getting thin. And that's because your body is really burning those proteins, and it's really burning your calories, but mostly your proteins. And so we really want to boost up that protein, all right? And I want it in you 6 times a day. I want 6 small little feedings, and I want protein with it every time we go. All right, next slide. All right, 2 to 3 ounces meals, 1 to 2 times in the fat. So this just kind of gives you a run of it. I'm not going to go through them, but you know, even alligator's protein when you're in South Louisiana. So it can be from many, many sources, and it's very lean and very good. So there's a lot of sources of proteins that you can use. So it kind of gives you a wide range. Next slide. Carbohydrates are your best source of energy. I don't even have to explain that because I had somebody explain that already, which is great. So, but it is your best source of energy. And carbohydrates get a really bad rap, don't they? You hear, oh, low carb. Well, no, that's your energy source. So when you go low carb, a lot of times you're starving. Starvation, I can get a lot of people to lose weight if I can starve them. You know, it's amazing how that works. But this is your energy source. You need these, and you need them 6 times a day. Little small amounts, all right? It can be fruits, it can be vegetables. I tend to use soluble fiber, which is the inside of the fruits and vegetables, and not the skins. If you're having diarrhea, there's 2 types of fiber, probably see this again, but soluble, and those can be absorbed in the body, and they kind of give a steady hydration to your bowel as you absorb them, and they go through the system a little slower. Okay, insoluble fibers are those the outside, the structures, and we always talk about trying to build this up in people to prevent constipation, right, and then have a normal bowel. But in people that are having trouble with diarrhea, that actually can increase your emptying. That's why we want other people to get it, right? We want them to have it because we want to empty them. You're plenty empty. I want something to stay with you. So we're going to do less of the insoluble, more of the soluble, and that's where you can get them pretty much in these sources, fruits and grains. All right, next slide. This is your grains. In a typical diet, we try to get 35 grams a day, probably much higher than what y'all will be able to tolerate. But to start with, and you do it, and you always add it gradually as we get it. You know, we don't want to, because it'll gas you up. Okay, it can be gassy. So easy to absorb, non-gassy. Some people may have heard of the FODMAP diet, fructose, and I don't use it straight as they wrote it, but I do give it to patients so they can see gassy foods. You know, it doesn't mean you're going to. It's really a good list, but just for you to know it, not for you to be real strict on it, not to try to stick to it necessarily, but it gives you an identification of some things that you may not know was really gassy. Okay. Low fiber is ordered, and if the low fiber diet is ordered, that's going to be less than 13 grams a day, okay? So if somebody's ordered you a low fiber diet, we're going the opposite way, okay? White breads can get you there, inside of potatoes. All right, next slide. So these are the ones, we saw these. Boy, wasn't this wonderful. If I could get people to consume and tolerate even the bread so that I can give you a wider range of foods, that's wonderful. I've had the opportunity over the last several years to work with a group of dietitians out of the UK and Europe. And the most interesting part of it is they don't have flushing over in Europe. They have a very clean system, and they don't have these problems. So I'm pretty convinced that it's and it's just my judgment, and especially since I'm doing this all over the country, it is definitely just my judgment. But I do think contributing is just what we put in it. We put so much junk in our foods, and some people try to get it shelf stable. How many of you put a hamburger bun in the kitchen and it lasts for 2 months because you forgot it, and it still doesn't have green stuff on it? So, I mean, we put a lot of things in our foods. So the cleaner, like they said, the better source of European grains and cleaner grains can help you. So, and they're not as hard to find as you used to. They're very steadily available. Maybe especially in cleaner places. People that are concentrating that, like this area, your area, compared to New Orleans. So, we also try to use things that are easy to absorb. Oatmeal, grits. Oatmeal may be the hardest of these. Grits can be used, which is a ground corn, and then cream of wheat, which is creamed. In other words, I want it already pretty much done, like it did the work for you, so you don't have to break it down, right? I already grinded it up for you. All right, next slide. Next slide. There we go. So fruits, we talked about the banana already. We do try to take the peels off of them, even on an apple or something like that. If you're having syndrome, if you're normal, And everybody, no trouble, eat that whole banana, eat that skin. But if you're having problems and you're having diarrhea or you're having a lot of GI trouble, or if you're at risk for obstructions, which if you've had a GI tract surgery, especially recently, you are, be careful with those. Canned fruits, we just don't use heavy syrup. Sugar causes diarrhea, okay? Sugary foods, from sources. Concentration, it's just osmolality, it's concentration. So those things are not easily tolerated. There's a lot of things packed in water, but canned fruits are good because they're pretty much broken down too, right? They're easier to tolerate at times. So there's patients coming out of the surgeries that I put on applesauce and baby food. Not often, but I have people that I've had to for, a length of time. So sometimes if these are broken down a little bit and you chop them up real good, the less your teeth have to do, especially after surgery. It takes a lot of energy to chew, doesn't it? It can wear you out. So whatever you can do to your foods already, cutting them, chopping them, things like that, mushing them sometimes, those things will help you because you won't get so worn out just trying to chew, okay? Avoid foods that are overripe. We talked about this already. And then we avoid foods that are real high in fiber. Pineapple's in there. Now, I love pineapple for people that can tolerate it because it has a bromelain in it, right? And that's one of the digestive enzymes. So there's things that can work, especially if you have a healthy gut and everybody's working good. So it's a wonderful fruit. I think it's really handy. But a lot of times I won't be able to get them to tolerate it straight out of surgeries and something. Watermelon is it's just different. It's kind of, and it's got a lot of sugar content, right? Dried fruits just have too much fiber sometimes for you. All right, next slide. The risk of obstruction is what I really worry with that. Cantaloupe's good. Melons are good. Very good. Very good. If you can tolerate the gas. Again, melons are gassy. But if you can tolerate it, and I think we call it honeydew melons. They're even a little bit less gassy. They're probably the least one. So vegetables. Guess what? I want them cooked. I like them chopped even, and instead of just being raw, because many times you need it broken down, all right? Because raw vegetables are hard to tolerate, hard to break down. We don't have a lot of acid in our stomach. Sometimes you've been given medicines to reduce your acids. And so just, again, I like them cooked. Fat soluble vitamins, the A, D, E, and K, which sometimes we get low in because you don't tolerate the fat, right? If you cook it and you put a little bit of a fat you can tolerate, a little bit of olive oil, a little bit of butter, whatever, then actually you absorb the vitamin A better. It carries over on that fat. Okay? You want to avoid things that can get stuck, like corn, and we talked about the obstruction, and it's a little rough on the GI tract. Pintos, black, and red beans are the hardest to digest for the beans. Now, you can eat other beans, and the peas, split pea soup, and things like that. Usually are tolerated pretty well. Cooked to a soft consistency. If you have a poor digestion, if you're just having trouble with digestion, just go down a little further, just kind of cook it pretty good. And then avoid cruciferous vegetables if you're having gas in particular, and those are the cruciferous vegetables here that I've got listed. All right, next slide. Low-fat dairy. Dairy is very important if we can get you to tolerate it. Dairy tends to be a little harder to digest because we have a lot of people that are just lactose intolerant or just never had lactose, and so they've never built enough of the enzyme. We do have enzymes for milk and these lactate tablets. There's lactate milk. There's different things that we can give you to get you to tolerate it, but there are other things that we can give you just to have liquid in your cereals, but they don't have all the protein many times and these other sources of a dairy type thing. So be careful with that. But yogurt's really good. I use yogurt in recipes quite often because they're easy to incorporate. Well, a lot of times when we use sour creams and other things we're used to, all you have to do is use that yogurt. It's the same flavor. It's enriched with protein, very high in protein, 8 grams. And we can get low fat, and you can do a lot with them. Make a lot of dips with them. Gives you options. Because when you're getting tired of the same foods, you need options. So we can do a lot with those options. Lactose-free, we talked about that. Low-fat American cheese, if you want to consider it a cheese. I'm not too sure it's really a cheese, but it can be tolerated. So cottage cheese and ricotta cheese, the same way. If you're getting the lower fats, they tend to work really well. And then like low-fat ice cream and things like that are fine. Next slide. Okay, so this just tells you a little bit about the serving size. As you can tell, you just want to avoid a teaspoon is a serving of fat. Right? That gets you a whole lot right there, right? Because we usually do it by the tablespoons, right? So you want to, the deep fried foods usually are not tolerated well, so it'll kind of lead you away from that. But remember, avocados are a fat source. They are a vegetable. They are a fat source, or fruit, and they can cause flushing because they do get soft as they ripen, and they can cause flushing. Choose light or reduced fat products. Use butter flavored powders. There's butter buds and things like that you can use and give you flavors outside of just the regular ones. And then use the healthy oils, olive oil, canola oil, and things like that. But they can still increase steatorrhea. There's an oil called medium chain triglycerides, and we use those in liver disease for many, many years because they are digested differently, go through a different pathway. And so I can get calories in you with that. So I use medium chain triglycerides, and guess what that is? Coconut oil. It got a little flavor with it too. Now that it really had a fad, about 5 years ago, it hit really faddish, and so people could find it. That was the only benefit to it. I was able to put it in regular stores so they had better access. And I tell you what, we didn't talk about, but there's a product with peanut butter even, where it's a powder. Have y'all seen that? And that's really handy for recipes as well, and it's got protein source. So these things can be found. All right, next slide. Okay, beverages, we still want you to have about the same amount of fluid as we did before, but that's hard for you to tolerate, right? You can't just drink it straight up 6 ounces, 8 ounces, so you're probably gonna have to do it 4 ounces at a time. So and when you separate it 30 to 45 minutes between your meals or after your meals, if you have digestion, and that makes all the difference. Sometimes that's all I have to change in patients, is to hold their liquids, sips of water to get your food down, but most of your liquids come 30 to 45 minutes between your meals, okay? But that means you got to plan them, right? But that will make some difference. Okay, as long as you use water, flavored waters, and all these things are fine, as long as they don't have caffeine and sugar in them. Remember, caffeine is a stimulant, and it's going to move that GI tract as well. If you're going to use juices, when I was talking about it, was it 13 grams of carbohydrates? Well, there's 15 grams in a half a cup of orange juice. So if you're going to use juices, you need to dilute them, okay? Or Gatorades and these drinks, dilute them with water. Try to reduce your decaffeinated, sugar-free, whatever your thing is, but those things are better. And carbonation can cause a lot of gas, so we usually go non-carbonated if you're having trouble with that. All right, next slide. Seasoning, use all the natural herbs and spices, all that you want. They're really good. They give a lot of flavor, and we don't have much trouble with them. Red peppers, cayennes, now that's a different thing. That'll light you up, and that'll trigger you. But most of these work really well. And then if you're having gas, onion is a gas forming and garlic is gas forming. And if you ever come to Louisiana, it's real hard to find a meal without onion and garlic. So you have to do a lot of your own cooking around there. But anyway, but just avoid the hot spices. That's the main thing. It'll really light you up for syndrome. Next slide. Okay, cooking and preparation, bake, broil, braise, saute, grill, but you're gonna avoid, you don't want it over direct flame. And the reason is not to do with neuroendocrine, it's just cancer safety. We know that if you cook and you have a flame hit your beef, hit your meat, it causes a byproduct, heterocycloamines, and this can be carcinogenic. This can cause cancer. So we don't hit direct flame, but you can still grill, but you move it away from the flame. Let it do its thing. All right, avoid raw when the immune system is low, and that's for fruits, vegetables, meat, everything. If you have a low immune system, really watch it. Use separate chopping boards, clean between all the raw and cooked foods. You don't use the same boards. Try to use separate boards and clean them. Always sanitize in between everything. Because more times than not, many times you have diarrhea, but many times we see patients go from all over, all walks of everything, just go to the hospital because they got a foodborne illness from not using clean, and they think, oh, I've got a bug. Well, no, you got food poisoning because you didn't clean your stuff good enough. So just remember that that's very common, so we got to really be careful and be clean. And then cook and store foods at appropriate temperatures. You do not leave foods out. You never leave foods out for a long period of time. Throw it away if it's been out over 2 hours. Don't go to a picnic with everybody and stay out, everything been out, pack it back up and put it in your refrigerator. Toss it all, okay? We don't save foods. If it has not been kept at a refrigeration, at above. You don't want it to stay between 90 and 40. Okay, about 100. You know, we want it to be higher than 140, and we want it lower than 30 degrees, if we can, 40 degrees at least. All right. So, but we do want it under. We don't want things left out. Next slide. Meal plans. This is the most important thing that I wanted to talk about. You're going to use a meal plan for the symptoms that you have. So if you're having trouble with aged foods, fermented foods, then we're going to take these foods out of your diet. So when I make a meal plan for you, I'm not going to put these foods in, all right? I'm going to take you off of those. Same thing, if I see that you're having problems, I'm going to take these foods, avoid meats, fruits that are associated with, out of your meal plan. In other words, those aren't going to be the things that we want you to try. MSG. MSG is almost in every food product in fast foods out there. Because guess what? It's a neurotransmitter, sorry. And so it tells you that you want something. It makes you crave things. It's what sends you back to food places that have it, and most of them do. They've soaked it, they've used it, and that's why you like it. That's why you're going back, okay? And so you want to break that chain for one thing. But it causes flushing to everybody, not just patients with neuroendocrine, so it's hard to tell what's going on with you if you're having trouble from these. And then avoid alcohol and its fermentation, a lot of times that. And I have some people that can do okay, and you know, I'm not trying to judge or manage, but I know that if you have diarrhea, sometimes this is real culprit we have to be careful with. All right, next slide. So meal planning tips. Make a grocery list appropriate for your symptoms. If you see something, and we have some great booklets that everybody's going to get today, and it has some of this material that I'm talking about, the avoids and use and some of that stuff. So, so you're going to see some of these in there. But make your list and try to stick to it when you go to the grocery store, because it's hard to go to a grocery store and not get other things, right? I was telling them today that I don't go to the store anymore. I try to get things delivered because I'm one of these people that I'm just an impulse buyer. You know, I can go for one thing and end up with a buggy full. So, so we try to make at least 3 days of meal planning at a time. We won't know who I am now. So that you have something to go. You write out the whole meal. You write out 3 meals, 3 snacks. And you look at those foods, and when you go to the grocery store, you take that list, you do it, and so that when you've got everything available for you. Because when you have to make a decision, when you get hungry, you're going to make the wrong decision. Because every time, I can tell you, especially doing fast food, fried food always smells better than roasted food, okay? So if you let your nose and your eyes track you to what is going to please your hunger, sometimes you're off, right? But if you know what you're going to do, and especially when you're going to you're going to doctor's office visits, and we know that's a big part, know what you're going to eat before it's time to eat. You know, really know what time, kind of what you're going to do. Even if you know you're going to be out of pocket, I know I'm going to have to grab something out. Maybe I'll go to this place. This food is a little bit better. I know I can tolerate it, so I'm going to plan ahead. Or do I have to take a sandwich with me or something with me that I'm going to need during this period of time? But it's real important that you not delay eating, because we know that can contribute to malabsorption. So just plan ahead. It's all planning, and that's what meal planning is doing for you. And you should always have a plan. This is so, so important, okay? Store foods after preparation in serving sizes so that you already have it. Makes it easy, right? If you've ever got everything in about a cup, an 8-ounce container in your freezer, half a cup. And people that want to bring things to you, tell them that too. If you don't mind, if you want to, just put it in the containers. Or if you're taking care of somebody with this, just do the little small feedings, because you don't want to waste food, right? We don't want it to sit out and age, right? So we plan ahead, and so that way you have these things. And then avoid leftovers. We already talked about that. Throw them out. Nothing, especially after 48 hours. I don't even want them after 24. Next slide. Fats, we talked about these, but that medium chain triglyceride, it is in some of the tube feedings and different things we use, but it's that coconut, not oil, obviously oil, and then butter. If you can tolerate a little butter, you know, I'm ready to see you do that than the long chain margarines. To be honest with you, they can drop your immune system too. Long chain, like fried foods, polyunsaturated fats, they have an effect, and when they go through all their systems, and they can actually decrease your immune system. So we don't want people that are already having a fight for their immune system to use a lot of fatty foods. And so you can see why there's different levels of problems with certain foods, and then they kind of got a bad rap. All right, next slide. Grocery store, don't go hungry. Take your list, read your labels, Replace the pantry staples. There's certain things you want to keep in there. Don't run out. Keep those things. Keep things that you know you can tolerate available in your house at all times. If you can't digest it and can't resist it, don't buy it. If you know that you've got a chocolate in the house, and you know your person, the patient, that can't tolerate chocolate, but they want it, put it somewhere else. Don't say, well, the families can't do without just because that person. It's not fair. Only bring what the patient can bring into that house. If you want to have things for everybody else, find a different spot away from where they're going to be going in all the time. Because when you see things you want and they trigger you, you're going to consume them, you're going to have the malabsorption problems with them, and then we get in trouble. So main thing, plan ahead. Everybody needs to have a plan, all right? Next slide. So small frequent feedings, we talked about this early. 6 small feedings a day from the different groups, and these are the different groups we've discussed it today. Next slide. Medications that make sure you know how to take your medicines. Are they between meals, with meals? They can change absorptions. If you're taking something like a pancreatic enzyme, you got to take it when you're eating. You know, I say don't take it. You need something there, right? You need them to be there when you need them. So you take them when you're going to eat, all right? Same thing with cholestyramine. People order it, and then it's not effective. And, well, I'll take it, but it doesn't do any good. Well, did you take it right before you ate? 30 minutes, or sometimes 20 minutes. And sometimes I have to give something during the meal because you're a slow eater. So I'm going to have to add one about halfway through your meal, all right? And then ask questions if you're unsure when to take them. So make sure you're comfortable with your medications because that are affected with foods. Next slide. Dining out, same thing. Look at the menu before you ever get to a restaurant. Call ahead, ask them what they have, tell them you've got special needs. I'm going to be coming with a group, but I have special needs. Most restaurants will really accommodate you, and they're glad to accommodate you. If you can talk to the chef, the head cooks, they'll if you can tell them, and you tell them ahead. Now, don't wait till you get to the restaurant and then say, oh, I've got all these things. You know you're going out to eat. You know where you're going. Plan ahead. All right. Contact the restaurant ahead. Take your medications as ordered. Take them with you if you have to take them with the meal so you don't forget them. Understand the word means. If you have something that says cream sauce, it's behind fat. I lost my shoe. Pureed vegetables. Sometimes I use pureed beets under of meat because it gives you a sauce, right? And it makes it easier to consume. So pureed beets work wonderful, and they're pretty on the plate. So I want you to eat from a rainbow. So I want to get all these foods in. I don't want you they always say, you just want white foods. No, I want everything. But beets are great. They're purple, give a lot of color. Carrots are great, a lot of color, right? But make sure you know what these things. Steamed and braised are usually a very safe thing to do, and tartar is a raw. So we don't want that. All right, next slide. Menus, just look through your menus. You know what you're going to have. I'm not going to go through all this slide. Go ahead. And then in conclusion, just remember that all, as we said before, just as the zebras have all different stripes, patients that are living with neuroendocrine, you've got all different stripes, okay? So see what works for you. Try foods. Keep a trial and error. We used to call them elimination diets. Just try something, and if you do good with it, list it on your list of goods. I can do that. That goes on your good list. That goes on your grocery list, right? That's tolerated, it's on the grocery list. You don't do good with it, all right, it's out. I don't do well with that, we're not doing that anymore, all right? That way you can see what does well for you. That's what I want you to do, trial and error, all right? See a dietitian. There are dietitians. I want you to see an RD. If you have neuroendocrine, I really want you to see an RD that is qualified because there's a lot of science that I'm not explaining today because it's science, and it's something that we've got the degree to do, and we can see things that you may not see, and we need to look at the whole picture. So I really want you going to see an RD that has qualifications and have that knowledge, that science background to be able to lead you through it. If you work with anybody else, you need them to talk to your RD, okay? Because it's people that think things are healthy tend to want you on these standards that they put in their heads or what's good for everybody else, and it does not fit for my patient client group. All right, with that, I'll be done. And I appreciate you, and I appreciate your time. And I hope this has helped. I lost my tag, I lost my shoe.
You should look amazing. So what an amazing lesson. What an amazing lesson. Actually, the real lesson there is, imagine if I took all that stuff and just changed it to cabozantinib or temozolomide or sandostatin or lanreotide. Is it on? Oh. So yeah, just imagine if I had changed the slides to lanreotide or octreotide or cabozantinib. I mean, it would be the same thing, the same kind of instructions that you're getting. So again, the food is medicine. And I think one lesson that's important to take home from what Leanne just said to us was that everyone's different. Everyone's different. So try, because that rainbow diet, you've heard me say it before. I know in your appointments, you've heard me say it, how important that is. Okay, perfect. Well, thank you, my darling.
You're very welcome.
This is 100 years of experience right here, 100.